finger out, there should be a little divot, right? That little divot between two tendons is the anatomical snuff box, right? So splay out, there you go. And we're poking right there. Yours is not quite as visible. You can see how mine is pretty visible. Yours is not quite as visible, but it's no big deal if it's not visible. You just feel for the tendons, your extensor and abductor tendons, all right, of your thumb and right in between that. Now this is very important. All right, because the scaphoid, and we're going to learn this, not next week, but the next, the scaphoid is in there, especially an adolescent, college age, or younger. When they fall on an outstretched arm, the potential for a scaphoid fracture is high. If you fall on an outstretched arm and you're a little bit older, like my age and older, you're going to probably have a distal radius fracture, right? So, but a scaphoid fracture commonly goes unseen on an x-ray, right? So if for some reason, again, and we've definitely caught these down the line, so if you have that concept, sometimes the x-ray doesn't show up initially, so they have to re-x-ray at a later time. Sometimes they have to do advanced like CT imaging to see it. And the problem here is the blood supply of the scaphoid. If there's a fracture of the scaphoid, you can actually have necrosis if they don't actually pin it back together. So it's a pretty big issue. So if you're having a person that's not getting better, maybe they haven't been x-rayed, maybe they were only x-rayed initially after, maybe they were only seen by a general practitioner, and you're digging around in the snuff box and all of their pain is right there, that would definitely at least warrant conversation with your therapist. Like, wow, it's only in the scaphoid. So this is a pretty big place to be able to palpate and understand, like if I'm poking right down in there, because really all I'm pushing on is bone. Now again, if I poke on there and it's just a little tender, I poke on the other side and see if it's a little tender over there. But if I poke in and they're saying, yes, that is all my pain, that's a good thing for us. We can find that easily, all right? So the MCP and the PIP and the DIPs, again, why would we palpate? The only reason we would palpate these is if they've said, hey, listen, I've had a dislocated finger, I jammed my finger, something along that line. But MCP, we need to know where they are, right? MCP are your knuckles, right? So it is good to be able to palpate them. Again, when we palpate them, it's almost like we did the clavicle, the SC joint. You want to move them around a little bit. These are joints, they move. So just touching it is generally not going to produce any type of pain, right? We're observant. Everyone's probably seen their grandma's fingers and she has some like bigger knuckles, right? Sign of arthritis there. So we're not going to get overly aggressive there, but we want to move it. And how we generally move it, well, we would stabilize one hand or one finger, and then we mobilize the other, right? So we're just seeing in between the MCP joints, is there any pain with that? Or even as I would slightly move it, again, my fingers are over the MCP joint and I'm kind of just slightly giving it some movement. One of my crepitus, pain with movement, right? Same thing at the PIPs and the DIPs, right? Remember, the thumb just has an IP, right? The thumb has a CMC, which we're going to palpate, an MP, and an IP. No DIP and PIP on the thumb, just an IP, right? So 4 DIPs, 4 PIPs, right? Again, on the distal and proximal, we would start looking, we would feel medial and lateral, especially if they say, hey, my finger's been dislocated, right? I'm going to feel, yeah, ulnar collateral.